So I'd like to open up my talk by asking you all a question, and the question is this. How many of you have tried to change the behavior of somebody you love? I think we all have, right? Whether that is squeeze the toothpaste differently, put the toilet seat down, get more physically active. But what do we know about behavior change? It's what I call character building. And although we teach students in our curricula how to work with patients on behavior change, whether it's to take their medication, get more physically active, we often don't apply those same principles to our own profession. We know, as Brandon said yesterday, he talked about 18 years. This nurse came back and they were still doing the same thing. And she was getting frustrated with that situation. But we, as with our patients, we got to assess readiness for change with nurses. Because if you think about it, the average age of a nurse in the United States is 47. So they didn't grow up with evidence-based practice. And I'm going to show you some very disheartening data from a study that our team did recently, that the older a nurse is from the sample that we surveyed, the less interested they were in gaining more education and skills in evidence-based practice. So even though we have made a lot of progress throughout the world in evidence-based practice over the past decade, we still have a very long time gap between the generation of research findings and their implementation in clinical practice to improve quality of care and patient outcomes. But there's more evidence coming out in the literature that visual triggers can help people with behavior change. So I wear buttons about everywhere I go, and I have a button on today that says, because we've always done it that way, with the slash through it. Because we really do have to think creatively and be willing to give up some very traditional practices just because we are comfortable with them. So I was in Georgia to do a keynote a few months back, and I usually take my buttons off when I travel through airports. But that day I happened to leave a button on, and that button said, "I love evidence." And I sat down next to a gentleman, and he kept staring at that button. And he finally said, "You love evidence, you have to be an attorney." And I said, "Oh no, I am not an attorney. I'm a nurse practitioner, and let me tell you all about evidence-based healthcare and why it's so important for your health." So we had a great 20-minute conversation about that, and when we were departing to board the plane, he said, "You know what, Bern? I see my primary care physician in 2 weeks, and when I go to see him, I'm going to ask him, are you an evidence-based healthcare provider? And if he looks at me like I have two heads, I'm going to go see an evidence-based healthcare provider." So we have a lot of not only progress to make in our profession, in our other health sciences professions, but we also have a lot to do with consumers, the public. I cannot tell you what a pet peeve I have when I do travel through airports and I pick up lay magazines like Prevention, Women's Health, Parents Magazine, and who's quoted all the time in those publications? It's physicians. We as nurses are such experts in health and in wellness, and we have to make a commitment to publicize and talk to the media a lot more and get nursing out there on the forefront of healthcare and health promotion. So we've got a philosophy at Ohio State, and that is in God we trust, but by golly, everybody else better bring data to the table. And we truly live by that philosophy. If you are negotiating, for instance, for more resources wherever you are, the more data you bring to the table, the stronger case you're going to make to get whatever it is that you need to advance evidence-based practice. Now, it's interesting because I've had the blessing to travel the world, actually, to help healthcare systems as well as colleges of nursing integrate evidence-based practice throughout their curriculum. And a lot of times I will hear from some professors, well, we need to wait until our students are juniors or seniors to really get them immersed in evidence-based practice. And I say all the time, no, we don't. We have to begin to educate our students about evidence-based practice from the time they walk in the door. We can be teaching them evidence-based decision-making. I've brought up my daughters to make evidence-based decisions so well that Kaylin came home one Christmas and said, Mom, I brought you the evidence on why you should pay $150 more for this iPad for me versus that one. So truly, we can teach it right from the beginning. Well, let's take a look at the state of healthcare worldwide. We have way too many medical errors that are happening every single day. In the United States, if you are hospitalized, you stand a 1 out of 10 chance of having a medical error happen to you. And if you have a medical error, 5 to 15% of you will either die or have permanent disability. Then think about all the wasteful healthcare spending that we do because providers don't follow evidence-based recommendations. We order way too many tests when they're truly not indicated. And again, a lot of procedures are done unnecessarily. And a lot of this truly is because evidence-based practice is not in the DNA of every practicing nurse, physician, respiratory therapist. See, that's my dream, that we don't have to talk about a course, 2 courses in EBP, but we start people from the very beginning, build and thread it all throughout the curriculum, so when they get out of their educational programs, this is the foundation from which they practice for the rest of their career. Because what you hear from so many nurses is, I don't have time to do this. This is on top of everything else that I need to accomplish. And so the mindset there is off, because the mindset should be, this is the foundation from which we practice. But think about this, and this is going on all throughout the globe, and I've seen it, So many professors in colleges of nursing are continuing to teach students the rigorous process of how to do research versus how to take an evidence-based approach to care. There are many folks who are still giving students critiques with about 80 questions to dissect one study. It takes them 2 weeks to do that. And our students get out and they say, this is unrealistic for the real world practice setting. We can't do this. Our professors are in the ivory tower. They don't know what it's like to be in the real world. So we've got a long way to go because, again, researchers, heavy-duty researchers, and I can call myself one of those people, we get comfortable. We've taught research this way for years and years, and it's hard to get out of your comfort zone. The other thing is, faculty cannot teach what they themselves don't know. And my wonderful colleague who's here today, Dave Rabbi, said that to me. He's like, Bern, we gotta know this stuff before we can teach it. So it's critical that we get our faculty really comfortable with the evidence-based practice skills so they can turn around and teach that approach to students and not digress to teaching baccalaureate students the rigorous process of how to do research instead of how to take a rigorous evidence-based approach to care. Well, then you look at my last point. Most research findings are never, ever translated into clinical practice to improve care and outcomes. So I had the privilege of serving on the United States Preventive Services Task Force for 4 years. And that is the group of 16 scientists who make evidence-based recommendations about what we're going to do in the United States for screening and behavioral counseling. At my very last meeting, the director of the Agency for Healthcare Research and Quality came to speak with us to tell us, thank you for serving the United States in this capacity. And she said to all of us, you know what the biggest problem we have in healthcare today? The biggest problem is we produce all this research, but so little of it ever makes it into clinical practice to improve care and outcomes. And think about what we do with our junior researchers and faculty when they come out of PhD programs. Many of them enter a Research One university, like my university, and they start running on that tenure track. And what are you tenured based upon? It's that you're federally funded for your research by National Institutes of Health, by HRQ, by the Centers for Disease Control. You are publishing up the wazoo, and you're nationally known for your area of expertise. So what people do is they grant write, they get rejected, they grant write, they get rejected, they grant write, then they do their study, then they publish, and they're right on to their next grant without thinking, how am I going to work with clinicians in the real world to get my findings out in clinical practice? Because I don't do research for the sake of research or just publishing it, although dissemination is critical of that knowledge. So I'm not saying that's not important. It really is. But we need to go a step beyond dissemination to say, how do I work with clinicians in real-world settings to now get my findings implemented? Well, getting back to medical errors, this is Kaylin. She's my budding veterinarian, and she's an equine fanatic. She loves horses. She's a competitive jumper. But Kaylin literally almost died about 8 years ago in Australia. It was our dream trip turned nightmare because of the lack of non-evidence-based health. I mean, they're the people, the physicians that we were interacting with, they weren't steeped in evidence-based practice. She had a ruptured appendix. And when we were in New Zealand, I diagnosed her. I said she's got early appendicitis. Took her to a medical facility, told them her symptoms, what I believed, being a seasoned pediatric nurse practitioner. Everybody said, oh no, this is the gastrointestinal virus your husband had 4 days ago. So we traveled on to Sydney for 4 days. I was filling her belly like 16 times a day for rebound and for guarding. We traveled to the outback, and that's where she spiked 104.5 fever and got seriously ill. We ended up in Cairns, Australia, took the next flight out. Kaylin had a 33,000 white blood cell count, a 92% neutrophilia, and a 36% BANS, a huge shift to the left. She had an emergency room surgeon, or a surgeon that saw her in the emergency room, that made her jump up and down on her right foot. I said, what are you what are you doing? This child has 104.5 fever. I'm telling you, she had an appendicitis. It ruptured. Now we're into a serious abscess. I said, where's the evidence behind jumping up and down on the right foot? He said, when a child can do this, they don't have an abdominal problem. They admitted her because I was begging and pleading. They called her a soft admission, and the head nurse of the pediatric unit said, the attending who called up to admit her said, we have a 9.5-year-old girl here from the United States with a very stressed out nurse mother who is insisting that her daughter be hospitalized, but this is a virus and she probably could go home. So for the next 18 hours, I told 8 physicians what I believed was wrong with Caitlin, how this is a serious situation, and how she needed just an ultrasound. Just an ultrasound. They wouldn't even do an ultrasound of her belly because her belly was soft, which fooled everybody. By the time they did the ultrasound, Kaylin had full-blown peritonitis, pelvic sepsis, and then a surgeon came in and said, your daughter's too ill to operate, so what we're going to do is put her on triple high IV dose antibiotics for 6 weeks in hopes that the body will wall that off, and then we'll go in and do elective surgery. Now, by the time they took her to OR, her whole peritoneum was filled with pus. They had to irrigate it for 2.5 solid hours. She was in the hospital for 2 weeks. We couldn't fly home for another week. I mean, but if I wouldn't have been so assertive, I hate to think of what would have happened to my daughter. And you talk about patient-centered care, like Brandon was talking about yesterday. The family's included in that. And part of evidence-based practice is a patient's preferences and values and what we are telling the healthcare providers. But so oftentimes, providers aren't listening to the patients and the families. And just like clinician expertise is part of evidence-based decision-making, so is a patient and family's preferences and values. So if you take a look at this model, what we tend to focus on mostly with our students is external evidence generated from rigorous research. Not much attention is given to internal evidence, which is the evidence that we gather internal to our practice setting. That evidence is very important, along with the clinician's expertise and patient's preferences and values. And everybody asks me everywhere I go, Bern, give us the magic formula. How much of our evidence-based decision-making should be based on research evidence? How much on clinical expertise and internal evidence, and how much on patients' preferences and values? And I tell people all the time, that differs based on every clinical encounter that you have. I might see a patient in my office who's a 3-year-old little girl with an ear infection that has not cleared with amoxicillin. And so the best evidence-based guideline might tell me, second line, I would prescribe Augmentin. But if this little girl's mom says, this little girl spits out Augmentin, she hates the taste of it, well, I'm not going to follow the evidence-based guideline there, because if she doesn't take it and absorb it, her ear infection isn't going to heal. So patient preference, what mother's telling me, has to enter into the equation with a heavier weight. So for the longest time, we taught clinicians the 5-step evidence-based practice process, right? And when we published our second edition of our evidence-based practice book, we said, there's really 2 more steps here to evidence-based practice, but we didn't want to confuse folks by jumbling 1, 2, 3, 4, and 5 up. So we added what we call step 0, which is cultivate a spirit of inquiry and a culture, environment that supports evidence-based practice. Because if you don't have a culture where a spirit of inquiry is really promoted amongst your clinicians or in your students, they're never going to get to step 1 in asking the PICO question. Now, I get a lot of feedback from clinicians who say, Bern, do we really have to put our clinical questions in PICO format? And I always tell people, you know what? The only reason we do that is to make your life easier. When you go to search for evidence, instead of asking a clinical question in non-PICO format that leads to 2 weeks of searching and yield of 1,000 abstracts, of which 990 are totally irrelevant, by using the keywords in PICO, we can reveal a search that's maybe 8 or 10 or 12 abstracts, of which will do a better job answering our questions. The last step that we added was disseminate the outcome. Present it, publish it. I was consulting with a hospital in the Midwest recently, And a team of nurses from one med-surg unit said, "We are so excited, Bern. We made an evidence-based practice change here on our unit to reduce falls, because we had a terrible problem with falls on this med-surg unit." I said, "Terrific, you're down to about 0. You evaluated the outcome. That's fantastic." I literally walked down the hall to the next unit, literally right down the hall, and I was talking with a group of nurses there, and I said, "Tell me what's your biggest problems on this unit." Guess what they said? Falls. I said, "Would you all get up and walk down to see your colleagues on the next unit to talk to them about the evidence-based practice change they made that decreased their fall rate to almost 0. See, we silo so much within the same hospitals and healthcare system and universities. We get in these silos that we don't share, and we don't disseminate the positive things that are happening so we can create this whole flood of positive evidence-based practice change. And then, if you're doing, say, an intervention study, intervention, you want to know about what intervention will help, say, to reduce falls. Well, the strongest level of evidence, if you have an intervention PICO question, is systematic reviews of randomized controlled trials. So that's what we need to look for first. But what's our problem in nursing with systematic reviews, sincerely? We have few of them relative to medicine. Medicine's got a lot of systematic reviews, because you know why? They believe in replication studies. It's so disturbing in nursing that I have seen faculty at universities really discourage PhD students from doing a replication study, because they say, you got to innovate, you got to do something. We're always reinventing the wheel. But if we don't have replication, how are we going to get to systematic reviews? And then, how much of our research continues to be descriptive studies? Now, I am not saying qualitative and descriptive work isn't important. It is important when we don't know something about a construct. But we know a lot about a lot of different constructs. And it's time to equip our nurses with skills in intervention research, comparative effective research, so we learn about what interventions work better and those that do not. There's still a lot of our practices that are based on lower level evidence. And we have got to speed this conduct of intervention research up in our fields. It's really important. So I equate the levels of evidence to chocolate. And how many of you are chocolate lovers here in the audience? About all of you are. So if you need a piece of chocolate, you're going to grab anything there. So I put Nestle's Quick Chocolates at the bottom of the chocolate evidence pyramid, and Godiva truffles at the top as level 1 chocolate evidence. Everywhere I go now, people tease me about this. And I was in Anchorage, Alaska, consulting up there last year, the year before, and they have a chocolate factory up there that's called Wild Berry Chocolates. And they said, Bern, can you please put Wild Berry Chocolates up there instead of Godiva truffles as level 1 chocolate evidence? And I said, bring me the evidence, I will test it, and then we'll figure out what goes up there. Everywhere I go as well, people ask me, Bern, how much evidence do we need to make that practice change? And I always tell people, the strength or the level of evidence plus the quality of that evidence gives us the confidence to act. Maybe we have a level 1 systematic review of randomized controlled trials published, but maybe those investigators did not do a rigorous job in conducting that systematic review. That's where critical appraisal is important as a step in evidence-based practice. So I want you to take the JASPA quiz. J, are you ambivalent about renewing your journal subscriptions? A, do you feel anger toward prolific authors? S, do you ever use journals to help you sleep? P, are you surrounded by piles of periodicals? And A, do you feel anxious when your journals arrive? And if you've answered yes to any of those questions, that's why we have to steep ourselves in evidence-based practice. Now, no matter where you are at around the world, because we got a nice diversity of people from all over the globe here, think about what is done in your clinical settings that's based on tradition instead of good, solid evidence. So I'll tell you about an experience I had recently. I was doing rounds at one hospital system in the Midwest, and a nurse comes up to me and says, Bern, I just had my attending physician write an order for sugar paste for a pressure ulcer. And I said to the physician, can you please tell me the evidence behind sugar paste? The physician, quote, quote, oh, I've used sugar paste for 30 years. It works so much better than any of these highfalutin new written methods for pressure ulcers. Well, that nurse, it was great. She asked a PICO question. She went and searched the evidence. She found a Cochrane systematic review of randomized controlled trials. She brought it back to the physician, and guess what she said? Dr. So-and-so, the evidence from this Cochrane systematic review doesn't support sugar paste. And do you know what he said truly? Mouth dropped open and said, you know about the Cochrane database of systematic reviews, seriously. But you know what? After that, he treated her differently and with more respect. You see, when nurses practice steeped in evidence, we gain more respect from our colleagues. So it's critical. But these are some of the things. Mayonnaise for head lice is a big thing in the United States. So again, what's the evidence behind mayonnaise? Providers are telling parents of kids with head lice to do this, and kids are getting staph and strep infections of the scalp when they're treated with this. We have never had a randomized controlled trial testing the efficacy of full-fat mayonnaise. I understand it has to be full fat, it can't be part skim, against nicks in the treatment of head lice. And everybody's doing it. Well, I'm not amazed kids are getting staph and strep infections. Put macaroni or potato salad out here yesterday for 12 hours, it's going to grow bacteria. So why wouldn't a child's head do that, right? So again, lots of stuff that we continue to do. You wouldn't sleep tonight if you would have been seeing the policy and procedure manuals that I have seen from consulting with healthcare systems throughout the past 5 years. Chief nursing executives, they get all jiggy when I say, can I see your policy and procedure manuals? So they're like, why do you want to see those, you know? But so many of them are outdated. They're not leveled based on evidence. So again, although we have made progress over the past decade in evidence-based practice, we truly have a long way to go. So we've got research up the wazoo to tell us, what are all the barriers that have prevented every nurse throughout the world from engaging in evidence-based practice? And these come up over and over and over again. Lack of administrative support, perceived lack of time. That's probably continues to be the biggest. I don't have time to do this. But again, the problem, a lot of the problem is we don't teach our students how to do this in a time-saving way. So again, they get out and say, this is unrealistic in the real world. So the negative attitudes toward research, boy, are they alive and well out there. They really, really are alive and well. We did a national survey. We took a random sample of nurses from the American Nurses Association. Because I don't know if you remember, in 2005, there was an article published in the American Journal of Nursing that gained a lot of media attention. And big, bold box, it said, United States nurses are not ready for evidence-based practice. That was the conclusion of that article by Pravikoff and colleagues. So our team said, let's get a contemporary assessment and see where we're at 7 years later with nurses across the United States. Well, here's a few of our findings. The more years in practice, the less nurses were interested in and felt it was important to gain more knowledge and skills in evidence-based practice. Again, this is a major problem because even if we do the best job of preparing our students to get out and practice in an evidence-based way, they're often going into cultures and environments where they might encounter older nurses who didn't grow up with evidence-based practice, who don't value that. Do you know in the United States, 35 to 60% of new graduates leave their positions in the first year? 35 to 60%. Because they're entering cultures where there's a discrepancy between what we prepared them to do and what they're finding out in the real world. Burnout amongst nurses is so highly prevalent. I was talking to another chief nursing executive. She said, Bern, I'm hoping you can get my nurses remotivated again and excited about their practices. And here's her exact words, because 75% of my nurses are functioning in a coma of complacency. Coma of complacency. Do you ever drive home some days and you don't know how you got there? Because it's so rote, you don't know how many stoplights you went through. We have a lot of nurses who are practicing task-based, and burn out. And she went on to tell me the story. She was in an elevator that morning with two of her emergency room nurses. And they were talking pretty loud. And one nurse said, "I'm so upset because my nurse manager gave me a rule-out heart attack patient a half an hour before my shift was going to end. And that resulted in me being a half an hour late getting out." She said, "That ruined my day." Now, they didn't know the chief nurse exec was in that elevator. And the chief nursing exec said out loud, "What do you think that did to that patient's day?" But again, this CNO went on to tell me, do you know how a lot of my nurses define whether they've had a good day? Their patient didn't die. They didn't make any medical errors. They checked off all their tasks, and they got a chance to go to lunch. Now, I think a lot of you are seeing people practicing that way. Where is the passion? And then there's so much burnout and stress. I don't know if you've seen the recent Gallup poll study on the health of nurses compared to physicians. The latest findings are nurses have twice the high blood pressure rates, twice the overweight and obesity, and twice the depression. Because you know why? We are not teaching our students and our clinicians how to take good self-care. We're teaching how to care for everybody else, but how about caring for themselves? And that's why at Ohio State now, we have formed a partnership with Johnson & Johnson's Human Performance Institute, and we have created or adapted their corporate athlete program for nurses. And we call it Nurse Athlete. And we teach nurses how they can stay more engaged, how to manage their energy better. Think about how much we sit every day, right? And when we sit, what's the largest muscle in our body? Here, right? And all that blood drains from here down here. We got to get up and move more. We have to have standing meetings more. In addition to reducing your cardiovascular risk, when you stand more, you get through meetings a heck of a lot faster than when you're sitting all the time. It's really true. So here's some other things that these nurses told us. A third of them said, "My colleagues consistently implement evidence-based practice with their patients." Only a third of them said, "Evidence-based practice mentors are available in my healthcare system to help me with evidence-based practice." You see, staff nurses, direct care clinicians, they're not usually going to sustain this unless they have good mentorship, hand-holding, a mentor who can guide them, help them with their PICO questions, help them search for the evidence, help them to make practice changes. Now, what we found, which wasn't yet found in the literature, we asked these nurses, what's the one big thing that prevents you from implementing evidence-based practice? Time, no surprise there, right? Organizational culture, no surprise there. But look at number 5, manager, leader, resistance to evidence-based practice. Now you would think all leaders and managers, because they want people to deliver a higher quality of care through evidence-based practice, they would be supportive. They would be role modeling the way for the clinicians. But that's what this group of a random sample of nurses across the United States said. My nurse leaders, my managers, they're creating a major barrier for me because they are not supporting this and they're not role modeling it. But this, sincerely, is one of our biggest barriers. It's colleagues in our work environment. It's those colleagues that our new students have to face who are steeped in this. That's the way we do it here. That's the way Dr. So-and-so says it's got to be done. And then one very important factor that I'm going to talk about now is we don't focus enough on the so what outcome factors when we do research, when we do quality improvement, outcomes management projects. We have to measure things that the current healthcare system is most concerned about. Because if we're not measuring those things in our research and in our evidence-based practice projects, what's the likelihood that a healthcare system is going to pick up your findings and implement them in clinical practice to improve care and outcomes? So we have got to be producing research and evidence-based practice quality improvement projects that have a big bang, that are focused on outcomes that matter to the healthcare system. And what matters in today's healthcare system? Money, cost. But how many research studies that we do in nursing include a cost-effectiveness analysis on what we're doing? Or think about the other things that matter, but they're linked to cost. Length of stay in hospital systems, readmission rates to the hospital, major complications that are costing hospitals money. So whenever I'm working with a nurse or a student on their evidence-based practice project or their research study, we say, number one, which so what outcome factors are you going to include in your study? We are still measuring a lot of warm and fuzzy outcomes that are not linked to these so what outcome factors that the healthcare system is really focused on right now. I'm a pediatric nurse practitioner. Believe me, I know the value of maternal warmth with their infants. But unless we link maternal warmth to breastfeeding, to length of stay, to decreasing complications, what is the chance that your research is going to matter in the real world? I would have died such an unhappy camper if I did 25 years of research to develop this wonderful intervention program to improve outcomes in hospitalized children and their families. And at the end of my life, 25 years or 30 years of grant writing and publishing and speaking all over the world, but yet nobody in the real world is using my intervention to make a difference for families. So we have got to slay some sacred cows that we have in nursing and speed this along and raise our students to be thinking about the so what outcome factors at the beginning of their projects. And why focus so hard on the so what outcome factors is because they reflect the impact that we are making as nurses in the healthcare system. It is so critical. So we also know what the facilitators are for evidence-based practice. We know when people have higher knowledge and skills, they implement this more. We know that when they believe in the value of evidence-based practice, when they believe in their abilities to implement it, they implement it more. We have now a lot of data to show when clinicians have EBP mentors in their environment to help them, they implement more. Administrative and organizational support, and then, very importantly, including the so what outcome factors. I was doing a keynote at a research congress last year, and there were probably 400 researchers in the auditorium. And I asked, tell me very honestly, how many of you can absolutely say today that the findings from your research are being used in clinical practice? Do you know how many people raised their hand? Two out of 400 researchers in that environment. But again, think about it. Why are you doing research? Why are you doing quality improvement, outcomes management projects? If the end result is just to publish, that's not good enough. The end result has got to be to improve care, to improve life for our patients and our families. So our team, and we're really excited about this particular work, our team is getting ready to publish hot off the press competencies for evidence-based practice in the real world. We had 7 experts nationally come together by consensus and develop competencies for clinicians who are in direct care and advanced practice nurses. And then what we said is, we got to get folks who live in the real world to tell us if we're on target with these or not. So we did a Delphi survey, and it took us 2 rounds to come to consensus on what these EBP competencies should be. So the plan is these should probably be published in January. So those are hot off the press. Now, other facilitators, champions, let's get excited about EBP. Let's get enthusiastic. So even if you don't feel enthusiastic today about evidence-based practice, would you please act enthusiastic for me? Because if you act excited, pretty soon you'll feel excited. And just like stress is contagious, so is enthusiasm. So many nurses have lost their enthusiasm for what they're doing. And we need to get more enthusiastic. So how many of you are enthusiastic about evidence-based practice? Woo! And one over here. I'm just seeing those of you who are awake. Okay, so let's be enthusiastic about what we're doing. Now I'm going to finish this talk by sharing a little bit of my research to really drive home the importance of the so what outcome factor, what we're choosing to measure in our studies. So about 25 years ago, and if you don't believe in the 17-year time gap between the production of research findings and their implementation in the real world, I'm standing here before you as living proof. But I am a 25-year time gap. 25 years it took me. Hundreds of presentations, multiple publications on my research program before any hospital adopted it in the real world. So I'm going to talk about one of my latest full-scale randomized controlled trials with COPE, my intervention for parents of premature babies. Preterm birth cost the world billions of dollars every single year. And we know preemies and their parents experience a lot of long-term negative adverse outcomes. So our team conducted a randomized controlled trial at 2 study sites, enrolling 260 low birth weight premature babies and their mothers and fathers in this trial. And we followed them for 3 years to really look at, could a nursing intervention delivered to parents that's easy to give, that's reproducible, it's manualized, could it have some long-term positive effects on outcomes? And here was our conceptual model based on self-regulation theory and control theory. We said our COPE program would strengthen parents' beliefs about what to expect of their preemie compared to a full term, and how they could confidently care for those babies. That, in turn, would decrease their anxiety, stress, and depression. It would increase their quality of parenting. And what we'd see as an end result would be better development and adjustment in the children. So the mean gestational age of our babies was 31 weeks, about equal males and females. And our program is a 7-part series of CDs with audio, education, information about what to expect in preemies, how they differ from full terms, how best parents could interact with those babies. So we start intervening very early on after the babies go into the neonatal intensive care unit. 2 to 4 days, then 2 to 4 days later, we come in with a second intervention, 1 to 4 days prior to discharge, a week after discharge, and then we continue to intervene at points where the babies would see their primary care provider. Because you always have to think about, when you do intervention research, what's going to be feasible. If your study shows your intervention is effective in impacting outcomes, is anybody going to adopt it? And the easier it is to give, the better chance that you stand of somebody adopting it. So that's what our materials look like. And again, we teach parents about how to read their baby's stress cues. When's the best time to interact with those babies? So what we found very quickly is parents who had received COPE versus parents who received an attention-controlled placebo program that basically just talked about the NICU services and policies. They had stronger beliefs about their babies, how to care for them. They had less stress in the NICU. We sent blinded observers in to watch these parents interact with their babies and found a higher quality of interaction in the COPE parents, less depression after hospitalization, but here was our so what outcome factor. We found that the preemies whose parents got COPE went home 4 days earlier from the neonatal intensive care unit, 8 days earlier for babies under 32 weeks gestation. So I, again, had been out presenting this research for a lot of years. Nobody was implementing this program in the real world until I showed the so what outcome factor, until I did and published a cost effectiveness analysis that showed we could save the United States healthcare system between $2.5 and $5 billion every year if every parent of a preemie born in the United States got COPE. Once I published that, guess what happened? My phone rang off the hook, and people started asking, how much does your program cost? How do we get the materials? Nobody mentored me beyond just publish your findings, not what to do and getting them implemented in the real world. So I started a company, and the company is called Cope for Hope, and that is our company that does the teaching with NICU staff, that disseminates the product, but nobody again taught me those things. We need to prepare our students for that. What do you do after you get success with an intervention and publish the outcomes? Then what are you going to do? How are you going to get it implemented? Well, my dream of getting COPE to so many families is really coming true. Because right now we have hospitals throughout the United States who are implementing COPE. In fact, Nationwide Children's Hospital in Columbus, Ohio, was the first hospital to integrate COPE as standard of care in their neonatal intensive care unit. They have gotten even a shorter length of stay than we did in our trial, and their rehospitalization rate has substantially dropped for those preemies. I was at the University of Bern in Switzerland last January teaching that staff in the neonatal intensive care unit how to implement COPE. So now we have COPE in German. We have just translated it into French. That is a researcher's dream come true, to see your work being implemented in real-world settings. Without the cost piece, I will tell you, still would not be happening. So I really encourage all of you, focus on these so what outcome factors when you are doing your research. Well, then we went out and we said, okay, we have the data on the efficacy of this program, but now we gotta test, how's it gonna work in the real world? So we did a dissemination implementation study to look at the impact and the best strategy for translating COPE into real-world practice settings. We had 81 nurses participate because this neonatal intensive care unit was under reconstruction. We couldn't do this particular study in all the pods. So we did it in half. At the beginning of the study, we had the nurses take our evidence-based practice beliefs and implementation scales. We did an 8-hour workshop on why evidence-based practice is so important. And here is the background on COPE and the findings. And then we gave them the program and said, now go implement it. Well, guess what happened in the unit? After 3 months of watching what was going on, hardly any parents were getting COPE. And so we're watching this, and we started meeting with the nurses, and they were like, Bern, this is a psychosocial-based intervention, and when we get busy, what do you think's gonna go? It's the intervention. And they said, we need help to keep us on track to implement this. So what we did after we saw so few parents were getting COPE, we put an advanced practice nurse in that NICU as a COPE evidence-based practice mentor. Once we did that, guess what happened? Nearly all parents of preterm infants received all phases of the COPE program. So again, we can't assume once we have an evidence-based intervention and we give it to people, oh, they're just going to go and implement it in the real world, because it often doesn't happen. So we need a lot more people doing translational work to find out what's the best strategies for taking evidence-based interventions and getting the uptake for those interventions in the real world. There's a lot of people who are confusing translational research with evidence-based practice. They're two different things. Translational research is rigorous research. It's finding out what are the factors that affect uptake in the real world. What are the strategies that yield the best uptake in the real world? Evidence-based practice is a problem-solving approach to the way we deliver care that integrates the best evidence with the clinician's expertise and patient's preferences and values in making the best decisions. So what we found from the nurses, barriers to implementation, it gets back to time, competing priorities. But the nurses also told us after they had an evidence-based practice mentor in the environment, it got a lot easier. So what we've done over the past 13 years, we have done studies to support the evidence behind our ARC model. So we have a model, a conceptual model for implementation and sustainability in real-world practice settings. What we do when we go into a hospital or healthcare system, we have a valid, reliable instrument of organizational culture and readiness for evidence-based practice. So we get data from that so we can assess what is this organization's strengths and what are their limitations in creating a culture and environment for evidence-based practice. But the key strategy in our evidence-based practice model is development and use of a cadre of evidence-based practice mentors. And those mentors then work directly with clinicians at the bedside to facilitate evidence-based practice. When you have those mentors in the environment, we have shown through our research, clinicians' beliefs about evidence-based practice go up, their confidence gets better about implementing evidence-based practice. That results in a greater implementation, and we've got two valid and reliable scales to measure beliefs and implementation. And then our latest studies have shown beliefs and greater implementation lead to these so what outcome factors. And we have 5 studies now that support the relationships in that particular ARC model. So what else have we learned from implementation science? How do people adopt findings from research in clinical practice? These are the factors that influence that, the characteristics of that intervention or practice. What's the strength of the evidence? How easy is it to administer? What is the cost? Characteristics of the clinician. Do they believe in this evidence-based intervention? Do they believe that it works? The environment, the culture of the organization, and the process through which that change is implemented. And I can't emphasize enough, we must make it easy and fun for clinicians to implement evidence-based practice. You see, do you know how many times I've heard from a clinician, do you think they really read a lot of heavy-duty research articles? They do not. They read abstracts. They want us to talk to them in a relatable way, not up here where they don't really understand what we're talking about. I mean, one of the things I'm so committed to as editor now of Worldviews on Evidence-Based Nursing is we gotta make that journal relatable for people to use. We want to provide the best evidence and be the #1 resource for evidence-based practice throughout the world. So we're incorporating new columns, like implementing and sustaining evidence-based practice in real-world practice settings. There's going to be a new column for tactics for teaching evidence-based practice. There's going to be new boxes at the end of every article with 4 to 6 bullets about what should we do now with this evidence in the real world. So we're really excited to build off of the tremendous foundation that Joe Rycroft Malone and the team built, and now leapfrog the journal to be the #1 resource for evidence-based practice out there. So that's the journal. I think, obviously, and I'm biased, it's the best resource for evidence-based practice. But I want to finish by talking about your dreams. And I know that sounds warm and fuzzy, but I have read the biographies of about 25 very successful people. And do you know what they focus on? Not the process of which they undertook. All of them talk about the dream that burned in their mind and in their heart every day when they got up in the morning. Now, I had the pleasure of speaking with Mark Spitz once. Do you remember who he was? He was so famous before Michael Phelps, right? An Olympic gold medalist. And Mark said, "Do you think it got me all jazzed up to wake up at 4:30 a.m. every single morning and go to a cold pool and look at a black line on the bottom of the pool and swim 5 and 6 hours worth of laps every single day?" He said, "That's not what got me excited to get up every day. What got me excited is, as I swam, I didn't see the black line anymore. All I saw was my dream of getting up on the Olympic platform and getting a gold medal around my neck." See, we have to cultivate our students, our faculty, our clinicians, how to dream more, how to vision what it is they want, the impact that they want to make for patients and their family members, because so many people have lost their dreams, and we need to cultivate those again. Not look at people. You know, do you know how many people look at me like I have 3 heads so often? Because I got a lot of big dreams for what we want to accomplish, to help people, to improve healthcare. But nothing happens unless first that dream. And I think one of the reasons we have 1 out of 4 people with depression anymore is because they've lost their dreams and their passions. So I'm going to ask you, if I could be your fairy godmother today and give you any dream or wish that you could attain in the next 2, 3, 5 years, what would you do if you absolutely know you cannot fail? What would you do? Then write that dream down and put it in front of you where you brush your teeth in the morning, so you keep looking at it and your brain keeps processing it. So I have this as a painting. It's only this big. Our college would do an event every year called Art for Health, where we'd get young artists through the city to come and display their paintings. We'd sell them, half of the profit would go to the young artists, half would go to our nurse practitioner managed health centers. Now, I used to always show a 2-ton chocolate elephant because I'm into that chocolate, right? One bite of the elephant at a time. But now I have a healthier version of it. But this was up on the wall at one of the events, and I walked in, and faculty students came up to me and said, "Bern, you're always talking to us about the dream, and one bite at a time. Go, there's a painting this year just for you. You got to buy it." So I walked around the exhibit. There was this tiny little painting up on the wall. I took it off the wall. I looked at the price. It said $600. My eyes nearly bugged out of my head, and then I said, wow, that artist had a really big dream when she put that amount of money on that painting. I bought it. And now I make posters of this to encourage people to dream big and take one bite at a time. I want to show this clip of a little boy with a big dream of being a professional baseball player.
I'm the greatest hitter in the world! Strike one. I'm the greatest hitter in the world! Strike two. I'm the greatest hitter in the world! Strike three. Wow. I'm the greatest pitcher in the world! Yes!
Optimism. Pass it on. A message from the Foundation for a Better Life.
That little boy was not going to be denied his dream. So, okay, maybe he wasn't going to be the best hitter in the world, but by golly, he was going to be a professional baseball player. Think about all the people in history who have struggled through a lot of character builders to accomplish their dreams. See, I don't have a bad day, I have a character building day. And it really helps you to put things into perspective. Thomas Edison's partner said, "Tom, I can't believe you've tried 9,000 ways to invent the storage battery and you have failed every single time." He said, "No, I haven't. I have found 9,000 ways. It doesn't work." What an incredible spirit. This guy who wrote the first Dr. Seuss book went to 23 publishers to get that book published. And they all said, "No, this is ridiculous, this story." The 24th sold 6 million copies of the Dr. Seuss book. See, I always say success is going from one failure to the next with enthusiasm. So next time somebody tells you no, get excited and say, "I'm one step closer to a yes." And I got to get back to the question. In the next 2, 3, 5 years, what are each of you going to do if you absolutely know you can't fail? And my favorite motivational speaker, Les Brown, always says, shoot for the moon, because even if you miss, you're going to hit the stars. Thanks, everybody.